All right, let's dive right in. Today we're going deep on something that's pretty fundamental for us as general surgeons, especially when it comes to managing those tricky esophageal cases. We're talking about the Chicago classification for esophageal motility disorders, and we've got a lot of ground to cover.
Definitely a cornerstone topic. This deep dive is all about understanding how this classification system really helps us make sense of these esophageal issues, how to diagnose them properly, categorize them, the whole nine yards. It's crucial for anyone who's dealing with these patients.
Absolutely. And, we both know that at the heart of it, this whole system relies on the information we get from high-resolution manometry, HRM. So basically, when we talk about the Chicago classification, we're talking about how to interpret those pressure patterns from HRM, those little squiggles on the screen, to figure out what's actually happening functionally in the esophagus.
Right. It's like having a decoder ring, right? It gives us a structured way to analyze those manometric findings and come up with a specific diagnosis for each motility disorder. Think of it as a standardized roadmap. It helps us decipher all the different activities going on in the esophagus, or sometimes the lack of activity.
Okay, so roadmap, decoder ring. I like it. So tell me, the Chicago classification itself, what's the basic structure we need to keep in mind as surgeons?
Well, at its core, it's all about hierarchical analysis. So we follow a specific sequence of steps, very methodical, and we use specific criteria to narrow down the diagnosis as we go. And it's really important to remember that this whole system, this classification, it's based entirely on what the manometry shows us. Those pressure profiles, those are the real indicators, the gold standard.
Right, purely manometric. No room for guesswork here. Now, I see they talk about a hierarchical diagnostic algorithm. Is that just a fancy way of saying there's a step-by-step process we need to follow?
Pretty much, it's like a checklist. We follow a specific order of criteria very systematically to arrive at the correct diagnosis. And just to keep everyone up to date, the current version, the one we should all be using, is the Chicago Classification 4.0 NOAO.
Good to know. Always important to stay current. Now, in broad strokes, how does the system categorize all the different motility disorders we might come across?
So, broadly speaking, it divides these disorders into two main groups. First, there are disorders of the esophagogastric junction outflow, the OGJ, that's basically the exit point of the esophagus. And then there are disorders of peristalsis, which affects the way the esophagus contracts and moves food along.
Got it. So problems with that exit gate, the OGJ, or problems with the actual squeezing motion of the esophagus itself. And what's the key factor that helps us distinguish between these two main groups?
The key player here is the integrated relaxation pressure, or IRP. We'll get into the nitty-gritty of this measurement later, but for now, just know that if the IRP is high, that's a red flag, a big one, that there might be an issue with that OGJ outflow, with that exit gate. So high IRP, that's where I start my investigation, no matter what else is going on in the esophagus.
All right, so IRP tells us which path to take, OGJ outflow or peristalsis. Makes sense. Let's start with those disorders of the esophageal body, the peristalsis problems. What's first on the list?
Well, one we see pretty often is distal esophageal spasm. You might remember it used to be called diffuse esophageal spasm, but the Chicago classification has updated the terminology.
Right, so DES is now distal esophageal spasm. What are the telltale signs on HRM that help us diagnose this?
The key findings are, first, a normal median integrated relaxation pressure. That means the OGJ is relaxing properly when the patient swallows. But then we see at least 20% premature contractions in the esophageal body. And on top of that, there's a specific threshold for the distal contractile integral, or DCI, which has to be greater than 450 millimeter HGS centimeter.
Okay, normal IRP, at least 20% early contractions, and a DCI over 450. So basically, the contractions are strong, but they're not coordinated, not happening in the right sequence. What's the next category under peristaltic disorders?
Next up is hypercontractile esophagus. This one used to have some colorful names like nutcracker esophagus or even jackhammer esophagus, which kind of give you a picture of how forceful these contractions can be.
Hypercontractile esophagus, so even more forceful contractions than in DES. What kind of findings do we see on HRM in these cases?
For this diagnosis, the patient usually reports chest pain. And then on the HRM, we need to see at least 2 swallows with a really high distal contractile integral, over 8,000 millimeter Hg (USD) centimeters. And these contractions can show up as single peaks or multiple peaks on the pressure tracing. But the important thing is the lower esophageal sphincter pressure, that's usually normal, and it relaxes fine with each swallow.
Wow, a DCI over 8,000. That sounds like the esophagus is going into overdrive. What kind of symptoms do patients typically have with that kind of intensity? Yeah, no kidding. Now let's switch gears a bit. What about when the problem is not too much contraction, but too little. What do we call that?
That's where ineffective esophageal motility comes in, or IEM for short. According to the Chicago classification version 3.0, this one's defined by having at least 50% of the swallows on the high-resolution manometry show either weak peristaltic contractions or no contractions at all.
Got it. So 50% or more weak or failed swallows. The esophagus is basically struggling to push food down effectively. Is that all we need to know about peristaltic disorders?
There's one more category we should mention called absent contractility. Pretty self-explanatory. This one means there's no measurable contractile activity happening anywhere in the esophageal body. It's another distinct type of peristaltic disorder in the Chicago classification.
Absent contractility, yeah, that was pretty clear-cut. Okay, let's move on to the other main category now, those disorders affecting the lower esophageal sphincter, or LES, and the OGJ outflow. The first one on the list, I think it used to be called hypertensive lower esophageal sphincter, is that right?
You got it. But in the Chicago classification, we now call it EGJ outflow obstruction. And the key finding on HRM for this one is a median IRP that's consistently above 15 millimeter Hg. That basically means the EGJ, that exit gate, isn't relaxing properly during swallowing.
So the sphincter's not opening the way it should. What about the contractions in the esophageal body itself? Are they affected too?
Interestingly, the esophageal body can actually have either hyperperistalsis, meaning it's overactive, or it can be completely normal. But the real clincher, the thing that confirms its EGJ outflow obstruction, is that elevated IRP.
So elevated IRP is the hallmark. All right, let's talk about achalasia now. We're all pretty familiar with this one. How does the Chicago classification define it?
So achalasia also has that elevated median IRP over 15 millimeter Hg. It means the LES isn't relaxing the way it should. But the crucial difference here is that there's also no normal peristalsis in the esophageal body. And to make things even more specific, the Chicago classification actually breaks down achalasia into 3 subtypes based on the different patterns we see on HRM. This subtyping is really helpful because it gives us more insight into how the condition might present and even helps guide our treatment approach to some extent.
3 subtypes of achalasia. That's interesting. Tell me more about those.
Sure. So type I, often called classic achalasia, shows that high IRP along with 100% failed peristalsis. And there's very little pressurization happening in the esophageal body. Basically, there's no coordinated movement and the esophagus isn't generating much force.
So no pressure, no peristalsis, and the LES is stuck closed. That's the classic picture we all know. What about type 2 achalasia?
Type 2 also has the high IRP and the 100% failed peristalsis. But here, the key difference is that we see panesophageal pressurization in at least 20% of the swallows. So even though there's no organized contraction, there is some pressure building up throughout the esophagus.
I see. So some pressure, but still no effective movement. And last but not least, type 3. I think this one is sometimes called spastic or vigorous achalasia, right?
Yep, that's the one. Type 3 also has the high IRP and the lack of normal peristalsis. But what sets it apart is that we see these spastic contractions defined by a discal contractile integral, or DCI, greater than 450 millimeter HGH estimeter happening in at least 20% of the swallows. So you've got the LES that won't relax, and then you've got these strong, uncoordinated contractions happening in the esophageal body. This step can be a bit trickier to manage.
So type 3 kind of combines features of achalasia and distal esophageal spasm. It's definitely helpful to have that subclassification to understand the full spectrum. Now, we've been talking a lot about IRP and DCI. Can you just quickly go over the precise definitions of these 2 parameters, just to make sure everyone's on the same page?
Of course. So integrated relaxation pressure, or IRP, like we said before, it measures how well the OGJ, that exit gate, relaxes during swallowing. Basically, it's the average pressure recorded over the 4 seconds where the relaxation is at its maximum within a 10-second window that starts when the upper esophageal sphincter relaxes. And we measure this pressure relative to the pressure inside the stomach. So the lower the IRP, the better the relaxation.
Lower's better.
Body.
Yeah. What about DCI?
Distal contractile integral, or DCI, that one tells us about the strength, the duration, and how much the distal esophagus is involved in the contraction. We calculate it by multiplying the contraction's amplitude, how high the pressure peak is, by its duration, how long it lasts, and by the length of the esophageal segment where the pressure is over 20 millimeter Hg, starting from the transition zone all the way down to the top of the LES. The units are millimeter, Hg, SDS, centimeter. It basically tells us how much oomph that contraction has, how powerful it is over a certain time and distance.
So amplitude times duration times length. That paints a pretty clear picture of the force involved. Now, putting on our surgeon hats for a minute, How does all this information from the Chicago classification high-resolution manometry actually influence our decisions in the clinic, when we're figuring out how to manage these patients?
That's the million-dollar question, right? So, manometry, with the Chicago classification as our guide, it's our go-to for diagnosing these motility disorders, no doubt. But we also need to remember that our patients, they don't always present in a textbook way. Their symptoms can be all over the map and often pretty vague. Like, you might have a patient with hypercontractile esophagus who just comes in complaining of chest pain, which could be caused by a million different things.
Exactly. Symptoms don't always fit neatly into those categories.
And another thing, and this is super important when we're thinking about surgery, the severity of the patient's symptoms, it doesn't always match up with what we see on the manometry. You can have a patient with a sky-high DCI who's managing pretty well, and then someone else with a less impressive DCI who's really struggling. We have to remember, we're treating the patient, not just the numbers.
Absolutely. The manometry gives us the physiological data, the objective measurements, but we can't forget about the patient's experience, their story.
Right. So the bottom line is, if we find a motility disorder on manometry, it really needs to be backed up by the patient's symptoms, what they're telling us, or by other tests to really be clinically significant.
So tell me, what specific information do these esophageal motility studies, interpreted through the Chicago classification, give us that's particularly useful when we're considering surgery?
Well, for one, it lets us really scrutinize the strength and coordination of those esophageal contractions. Are they strong enough to actually move food along? Are they happening in the right order in a nice coordinated sequence? Figuring out the specific motility disorder helps us understand what's going wrong functionally. And it also helps us assess the LES, the lower esophageal sphincter. Is it relaxing the way it should when the patient swallows? Is it too tight, too loose? These are all critical things we need to know before we even think about going to the OR.
And how does this detailed information help us tell the difference between different conditions that might present with similar symptoms?
That's where it gets really important. It helps us distinguish GERD from other things like achalasia or scleroderma, which can also mess with esophageal motility. Making the right diagnosis is crucial because how we approach surgery for GERD is completely different from how we'd manage achalasia surgically. And even more importantly, if a patient has both GERD and a motility disorder, the manometry can help us tailor the surgery to tackle both issues effectively. Like if someone has bad GERD but also has weak esophageal contractions, a tight Nissen fundal application might not be the best choice. It might actually make their motility problems worse.
That makes perfect sense. We need to know what we're dealing with in terms of esophageal function to pick the right surgical strategy and avoid making things worse. So the Chicago classification gives us that framework, that structure, to interpret the manometry and apply it directly to our surgical decision-making.
Exactly. It gives us that standardized approach. It helps us make sense of all that complex data and make informed decisions about how to manage our patients, especially when surgery is on the table. And like you said, it's constantly evolving. There have been several updates and revisions, each one making the diagnostic criteria even more refined and clinically useful.
So to sum it all up, the Chicago classification is our essential tool for understanding and categorizing esophageal motility disorders based on high-resolution manometry. It gives us this detailed, precise way to define different conditions based on specific manometric patterns, especially focusing on those IRP and DCI values. It might seem technical at first glance, but the ultimate goal is to give us a clearer picture of how the esophagus is working or not working, so we can provide the best possible care for our patients.
Couldn't have said it better myself. It leads to more accurate diagnoses and ultimately helps us come up with the most appropriate treatment strategies for our patients who are dealing with these sometimes very challenging esophageal disorders.
This has been a really valuable deep dive into the Chicago classification, especially for us as general surgeons. It's a dynamic system, always evolving, and really understanding all the nuances is absolutely critical in our field. Thanks for walking us through it.
Happy to do it. It's a fundamental part of how we approach and manage these conditions in our practice.
And for all of you listening out there, fellow surgeons, as you continue your practice, think about how this detailed classification system, even though it might seem very technical, it's really all about gaining a deeper understanding of how the esophagus works in all its complexity. And that understanding is what allows us to provide more precise, more effective surgical care for our patients. Until next time.